Right evening, everyone. Welcome to the third webinar for the Sarcoma Foundation. We'll be on bone tumours, and we're very lucky to have Professor Craig Gerrand, who's Professor of Orthopaedic Oncology at University College London, and a consultant orthopaedic oncologist as part of the London Sarcoma Service, and works at the Royal National Orthopaedic Hospital, and a former colleague of mine when I was fortunate enough to work there also. Craig also heads up the Sarcoma Advisory Group for the London service with the Royal Marsden, and is cancer lead for the Royal National Orthopaedic Hospital, among many, many other roles and talents, which is why he looks so haggard. We've had a few technical issues with Craig's English computer struggling, and so he's going to use my computer to give the talk. So without further ado, I'll hand over to Joanna, who's going to chair it, and we'll sort out Craig's PowerPoint.
Thanks, Andy, and kia ora everyone, and thank you for everyone joining online tonight, and just a big warm welcome to Craig for doing this webinar for us. So as always, the format will be a presentation. Please feel free to put some questions through in the Q&A rather than the chat. And what we'll do at the end, we'll go through some of those questions and ask Craig things that you really want to know. So Craig, when you're ready, let me know, and we'll kick off.
That's great.
Thanks, Craig.
Yes, thanks very much. Thanks for that introduction. Yeah, I'm only 35 years old. It's been a hard paper round, as they say in the west of Scotland. But it's a great pleasure to be here. Can you see my slides? You see my slides? Perfect.
We can, thank you.
Yeah, great pleasure to be here in this beautiful country, and I've managed to spend a bit of time having a look around, which is excellent. And I'm looking forward to joining Andy at the MD2 tomorrow. But yeah, so as you said, I've been doing this job as an orthopaedic surgeon for quite a number of years, initially in the northeast of England and latterly in London. And so I'm an orthopaedic surgeon, like Andy. And so he asked me to talk about bone sarcomas, which I'm happy to do. But most of this is about the surgical aspects. And so a bit of a heads up that I will show some surgical slides, which I know are not to everybody's taste. But I think it's important to kind of show what it is we do and to illustrate some of the points. So this is the hospital where I work. This is the Royal National Orthopaedic Hospital at Stanmore, which is well known for the slope corridor, which you can see on the left. It's like many hospitals in the NHS. Lots of parts of it have seen better days, but it is slowly being rebuilt as funds allow. And so we're very pleased to have had 4 new theatres in recent times, just from the top right, a new inpatient building in the middle, and an outpatient building in the centre of London at the bottom. So things are making progress. So the hospital sits here within the London and South East Sarcoma Network. So the UK is set up with what used to be called cancer networks, but are now regions, if you like, which drain to specialist centres. And so you can imagine that given there's a bigger density of population in the South East, this is quite a lot of people who are in this part of the country. So we cover about a population of around 20 million for primary bone tumours, and they're patients of all ages. And we see a slightly smaller population of people with soft tissue sarcomas in the pelvis and extremities. And you can see from the map on the right that one of the features of having a bone tumour is that there's a lot of travelling to do. And this map on the right shows the kind of journeys that people have to travel to the various specialist centres in the UK. So I work with a lot of people, and this is a photograph which includes Mr. Johnson in the far right. This is an example of the team of people that I work with. And so this includes, as I'm sure you're aware, surgeons, oncologists of the medical and the radiation variety, pathologists, radiologists, and of course a very important CNS team, MDT coordinators, data managers, and so on. So I'm very privileged to work with this team of very motivated people. So we're going to talk a bit about what are bone sarcomas and something about surgery. And then a particular thing I wanted to talk about was what life is like after treatment, because the life tends to be irreversibly changed after a diagnosis of bone sarcoma. And I thought we'd talk a little bit about that. So what are bone sarcomas? Well, you may well know these are primary malignant tumours which arise from bone. There's many different types. So this is a rare kind of tumour, and there's lots of different kinds of them. So this presents a number of challenges, including diagnostic challenges and treatment challenges, and it includes all ages, including particular teenagers and young adults. And you'll see the table on the right, which is from the guidebook for this, has the classification of malignant primary bone tumours, basically describes them as what they look like under the microscope. So some look like cartilage, some make bone, some look like fibrous tissue. This is a very old school way of looking at the way cancers are, and it's likely that over time we'll be looking more and more at tumours in terms of their genetic variability and the particular fusions and the genetics that make them that drive tumour formation and actually are often targetable. But this is where we are at the moment, so many different kinds. This is data from NHS England and shows that we have a bit over 120 osteosarcomas a year, slightly fewer chondrosarcomas, although interestingly that number has gone up a bit recently, about 50 odd Ewing sarcomas and the rest. And this shows, again, from NHS England data, what the age distribution is. And you can see there's a peak in the blue line, which is for osteosarcoma, and the orange for Ewing sarcoma in teenagers and young adults. And the purple line for chondrosarcoma gets the frequency increases with age. So this is a tumour that generally has quite a long development phase. And so people with rare cancers, often the diagnosis is delayed. They can be misdiagnosed, and we know that misdiagnosis is something that really puts a spanner in the works of getting to the diagnosis. It's difficult for people to access care. They have to travel. There are uncertainties about treatment. Clinical trials are difficult and involve collaboration across international boundaries. New treatments may not be commercially feasible, so drug companies are not particularly interested in them. And it's particularly difficult in pediatric cancers where you have a small number of patients. From the patient perspective, this is rare. Patients are often incorrectly reassured. They have to travel for treatment. The charities, certainly in the UK over the last 20 years, the Bone Cancer Research Trust and Sarcoma UK have made a huge difference. And it's a delight to see the Sarcoma Foundation here in New Zealand making a difference, because these charities bring a patient voice to all of the conversations we have nationally about the treatment for sarcomas. And actually what they've been able to do in recent years is fill in the gaps where perhaps the NHS hasn't been so interested in developing services for sarcoma patients. So kudos to you for having this, the Sarcoma Foundation, and I think it's going to make a huge difference for sarcoma patients here in New Zealand. So we'd like, ideally, patients to have early diagnosis, to get a planned biopsy. The treatment should be individualized. You've seen a whole range of diagnoses, but also tumours occur anatomically in a wide range of places. And of course, people are very different in what they expect and their activities and so on. So treatment has to be individualized. We'd like all patients to have access to expert multidisciplinary care. And then we'd like them also to be looked after afterwards so that they can optimize what their life is like. So typically for a patient with an osteosarcoma, they would have a diagnosis and staging studies. The question being, has the tumor appeared anywhere else in the body? They would get neoadjuvant, so before surgery, chemotherapy and radiotherapy. They then have an operation, and almost without exception, you need an operation to be cured of your bone tumor. You may have chemotherapy or radiotherapy afterwards, and then you'd have a follow-up program. And so my bit would be to contribute to the diagnostic piece. So patients will very often see surgeons or surgical teams initially, but then we'd also get involved when it comes to the operation. And the principles of the operation we want to do is to completely remove the tumour. I think that goes without saying. And quite what that means depends on where the tumour is, what it looks like on the scan, what we know of the tumour biology, whether or not it's responded to treatment. We want to leave people with as much function as possible. And so we're always walking this tightrope between removing more things and improving our margin and causing the patient more loss of function. We'd like our surgery to occur without interfering with other treatments. So what we don't want are big delays in, for example, a chemotherapy regime when we know that chemotherapy is really important. We'd like patients not to have complications. We'd like to return them to a normal life. We'd like a treatment that is acceptable to the patient and family, in which they don't regret later when there are choices. And of course, it needs to be cost effective. And these are expensive operations. And what you can see on the right is a custom-made total femoral replacement, which is a growing implant, which retails at about £50,000. So that's a lot of money. And if that gets infected, that implant has to come out. So these things can be very expensive, although cisplatin, I understand, is even more expensive. One of the questions we ask as surgeons once we've removed a tumour is whether or not we should do a reconstruction. And there's a bunch of things that we would think about before doing a reconstruction. Like, what is the diagnosis? How extensive is the disease? Does the patient need chemotherapy or radiotherapy? So we know that radiotherapy to a limb that's had an implant in it does increase the infection rate a lot. We're also interested in the prognosis of the patient. So if a patient has a poor prognosis, we wouldn't necessarily want to give them an operation that means they can't weight bear on a leg for a long period, for example. We're interested in how old the patient is, what they're interested in doing. Are they, for example, very sporty? What's their preference? And in general, the options are no reconstruction, an endoprosthetic reconstruction, which is a big bit of metal, or a biological reconstruction using a bone, either from the patient or from someone else. And we'd like to do this in a shared decision-making fashion. So that means where there are surgical choices to make, we'd want to seek patient participation, discuss the options, find out what matters to the patient, and help them make a decision, and then evaluate it afterwards. It's very difficult in amongst a cancer diagnosis and cancer treatment to get the time and the focus, if you like, on this, on the surgical treatment during what is a massive upheaval very often for patients and families. So when they've come to terms with the cancer diagnosis and they've had chemotherapy, and then in quick measure they have to discuss what kind of operation you might have, there's a lot of challenges to getting the right solution for that patient. So let's show you some surgical examples. Some tumours and some bones we can take out and they don't need to be reconstructed. So here's the fibula in a child. So this is below the knee. You can see this patient's a child because there is a growth plate both above and below the knee. And the fibula is a bone which we can remove without having to do reconstruction. And in fact, it's a bone that we often use for secondary reconstruction. Just has muscle attachments. And so the morbidity of removing that is usually relatively small. Here's a chondrosarcoma in the pelvis. So it looks like popcorn. You can see that on the right side above the right hip. And that's, again, an area of bone that doesn't need reconstruction. That you'll see on the right-hand side after surgery, the hip is still connected to the spine, and so the weight can go through that. And actually, this patient did very well. There are muscle attachments there, and so you would expect the patient to have a little limp. And in fact, he went back to a manual job after this surgery. Some bones, another bone you don't need to reconstruct is the clavicle or the collarbone. And this is the patient who's had the collarbone removed, and you can see on the right side they've got a full range of movement of the shoulder. And although some people do go to extraordinary lengths to reconstruct the collarbone, it's really not necessary. And this patient also went back to quite a heavy manual job. Probably our standard reconstruction is to use a big metal implant or an endoprosthesis. These are quick, they allow early weight bearing, they're cost effective, and we know what the results are like. We put enough of these in over the years to understand. But there are risks. Infection is a serious risk. So these are long operations that happen in patients who are often in the middle of chemotherapy, who have very large soft tissue flaps. And so the infection rates are generally very high. They're much higher than, for example, a knee replacement for arthritis. We know that implants can loosen or wear. We know the results depend on where these tumours are in the body and which bones are reconstructing. And they often include a joint replacement. And a joint replacement in a child, for example, will wear out or loosen at some point. Here's some examples. This is a teenager with an osteosarcoma of the distal femur. So you'll see on the left-hand side, the X-ray. You've got a scan. An MRI scan and axial section, which shows the tumour growing out of the bone into muscle. And then what we've done is we've resected the whole of that bone and tumour covered with muscle. And there's a standard reconstruction on the right-hand side, which is a custom-made implant, but it has a knee replacement in it. Here's an older gentleman who's had a fracture through what turned out to be a dedifferentiated chondrosarcoma, which is a primary bone tumour. Quite an aggressive one, but we were able to remove this and replace more of the femur, this time using a modular system. So we could do this quite quickly. We didn't have to wait for a custom implant to be made. And you can replace In fact, you could replace the whole femur if you need to. The proximal humerus around the shoulder can also be replaced, and here's an example of a shoulder replacement. The shoulder is a very mobile joint, and probably the biggest issue with shoulder replacement is instability. So the shoulder will often dislocate because you've had a removal of a lot of muscles. So there are various implants that are actually physically linked to each other to try and reduce the risk of dislocation. And sometimes soft tissue coverage is a problem. So this is a patient who's had removal of the proximal ulna and the elbow. So you can replace this, but we've spent some time reconstructing the extensor mechanism, so-called, so the patient can extend their elbow. And that's particularly important, for example, when drinking a cup of tea, because if you can't keep your elbow in extension, you'll pour the tea all over yourself. So that's can be challenging. We often use custom implants. There's a Ewing sarcoma of the femur. You can see it growing out from the femur on the scans there. And it's nice to do an operation that preserves the joints. And what this shows is a custom-made jig. It's an older variety. We have different designs now, but the plastic you see on the top left sits on the bone in only one place. So it's a custom jig that's made for this patient. It's 3D printed. We send a CT scan of the limb off. And plan exactly where we're going to cut it, and this implant sits in exactly the right place. We can then remove the tumor, which you see in the kidney dish in the middle section, and then the implant sits very nicely, and you'll see that it fits exactly where we planned it to fit on the image on the right, and that's a reconstruction that will give that patient very good function. In the tibia below the knee, this is a classic problem. The soft tissue cover is very poor, and so we have to reconstruct the extensor mechanism, which straightens the knee. And so this is a series of slides that shows that. And what we usually do is take the gastrocnemius muscle, which is the muscle from the calf, and swing it over the front. And you'll see by the time we get to the bottom picture that the implant is completely covered with muscle. The patellar tendon, which straightens the knee, is connected to that muscle, and that allows the knee to straighten. And in children, this is an implant that was developed at Stanmore some years ago, which has a motor in it, and this will extend the bone to allow for growth. So if you remove the growth plate from the distal femur, that has a significant contribution to the overall length of the leg. And whilst you could do an operation to put a longer implant in, having an implant that grows has a lot of advantages. And this implant has a motor in it. And when you put the leg inside the magnetic field, which is what you're seeing in the middle picture, it spins the motor and the device gets longer. And that's been a huge benefit to patients who could then avoid multiple operations. It's not without its issues, but it's been a very helpful device. But of course, there are complications, and here's a list of complications like loosening, infection, instability, fracture of the implant, and so on. And so when we do these operations, we have to consider this, and patients go into follow-up, obviously, and very often they'll have to have further operations down the line. Ideally, for some patients where you can, it's good to use biological reconstructions. Okay, so we'd use bone, and typically we would use bone from another person. That's called an allograft, or a bone from the patient. Allografts, so bones from somewhere else, are good. They can have soft tissue attachments on them. You can shape them to fit the defect, but they have complications like infection. They can be difficult to get, so you have to size match them. What we've tended to do recently when we put in allografts is get custom-made jigs for them. So we design the operation, we'll design where we're going to cut the bone in the patient, and then we'll scan the allograft and also get jigs for the allograft, which means that we'll cut the allograft in exactly the shape that we will predict from the patient. We can also use bone from the patient. That could involve, for example, taking the bone out with the tumor in it, irradiating it, so it would go off to another hospital for radiotherapy, and then reimplanting it. That's very good because it's cheap. The bone that you put back in fits the patient, fits the gap exactly. There's no risk of disease transmission in the way that there is with for example, a blood transfusion or with using a bone somewhere else, although that risk is very low. And if you're careful with it, and if you use the fibula in a young child, it can grow. But these are complex operations that obviously do have complications. So here's some examples. Here's a tibial reconstruction using an allograft. And so this you'll see a predictable segmental defect once we've taken the tumour out on the top. And then what we've done is we've taken an allograft, which is donated bone. We've actually filled it with cement, which is quite a good technique for bringing antibiotics in and for improving the strength of the allograft. And then we put 2 big plates on it. And you'll see on those x-rays, particularly the one on the far right, that actually the junctions have healed. And so we would expect that to be a very durable reconstruction for that patient. This is a patient who had an osteosarcoma of the distal femur, a low-grade osteosarcoma, so he didn't need chemotherapy. But what we've done there is we've taken the bone out, irradiated it, and reimplanted it. And so we've managed to keep his knee, and he had very good function in his leg. And once that has healed at both ends, and you'll just see it hasn't quite healed in that X-ray, although it did go on to heal. Once that has healed at both ends, that again is a very durable reconstruction for that patient. If you'd like to use some living bone to do some of this, then there is an operation called the hot dog, which we do not infrequently in the tibia, where we take an allograft, cut a channel in it, and you can see that rather gory picture in the middle is an allograft with a channel cut in it. And then you can move, what we've done in this case is move the fibula bone across with its blood supply to go in the middle of that bone. And that has the advantage that it would heal at the top and the bottom. So it's going to work a little bit better. And gradually that bone will heal to the fibula, and you'll have something that's very solid. Unfortunately, when you put bone in, like this, a massive allograft, it's said to be like a telegraph pole. In other words, it doesn't grow leaves, although it's made of wood, if you like. So it never completely becomes biologically integrated, but it does heal at both ends, and that's quite a useful technique. This is an example of taking the fibula from the leg and using it to reconstruct, in this case, the radius, a child with an osteosarcoma of the radius. And we've taken the fibula with the blood supply and managed to do some limb salvage so the patient could keep his hand. In fact, he was a very keen piano player, could keep his hand, and we've fused that fibula into the wrist and into the proximal radius. And what you see in the top right is a vascular anastomosis. So you might just be able to see 2 vessels here, which is the artery here, which has a Doppler device on it, which makes sure that it continues to function after the surgery, and the vein next to it. And this is a technique done by plastic surgeons. So we would work with a plastic surgical team to do this sort of operation. A bit about the pelvis. These tumours often present late. They're very large. There's many important structures in the pelvis. It's very hard to remove tumours completely. We tend to use navigational technology or jigs to make sure we've cut things exactly where we planned it. These operations tend to be associated with a lot of blood loss and wound complications. And doing a bone reconstruction in this situation has a high risk of failure and complications, but it does give better function. Here's some examples where we haven't done a reconstruction. On the right side, this patient's had the acetabulum removed, and we decided not to reconstruct it. And the femoral head has migrated up into the pelvis. The patient has a short leg, but they're able to walk around on this, and they are extremely unlikely to need any more surgery. So that's job done, if you like. And so that's why we've chosen that. On the other side, this is a patient who's had the pelvis above the acetabulum removed. You can see that there is, in both these cases, there is a little bit of spinal curvature, there is a little bit of leg length difference. But again, this is something that we wouldn't necessarily reconstruct because the benefits of reconstruction are outweighed by the complications. Here's a case just to show you the sort of navigational technology that you can use, a low-grade osteosarcoma in the pelvis. And we've planned this resection several planes. This was actually a complex multi-planar resection. You can see there's a cut there. The bit that we've taken out has a kind of polygonal shape around the outside, and we've been able, using surgical navigation, which tells you exactly where your tools are in the pelvis, to cut a complex shape, get the tumour out, and still preserve as much of the pelvis as we can. Just in the interest of time, I think I'm going to tick on a little bit. Sometimes, unfortunately, for pelvic tumours, we do have to do an amputation, and you can imagine that that is at a very high level is something that is extremely disabling and disfiguring, but that is necessary. This is a patient with a huge chondrosarcoma in the pelvis, and it goes right over to the left hip. It fills up the pelvic floor. The bladder is on the front of it, And really, we had no alternative to an amputation for this patient. Although I have to say she has done extremely well, is extremely positive, and is a great example of how you can get on with your life after this sort of surgery. But with a huge tumour like this in the pelvis, we really don't have any other options other than surgery. There isn't another treatment that would get rid of that. And so that brings me a bit to amputation, to say that it's not necessarily the case that everyone could or should have limb sparing. Having limb sparing operation is easy to talk to patients about. There's generally less disability. It looks normal if you can save a leg, although the leg itself will often have a large scar, maybe thinner, and look a little different. But limb sparing leads to, there are complications with that. You need revision surgery, there's risk of local recurrence. And when we did a national survey of patients who'd had amputation, what these graphs show you, on the left-hand side is a measure called TESS, which looks at really a measure of disability. And what you have, those bars essentially are different amputation levels. So on the left side, it's physical function. On the right side, it's quality of life. And what you can see is that on the left side, if you have a hemipelvectomy, you are quite disabled, or a hip disarticulation. Your functional scores are quite low, but your quality of life is pretty much the same across the patch, unless you're having a very minor amputation. And so what I often say to patients is that if you do have to have an amputation, it's not a disaster, because we know you will get on with your life, and your quality of life can be as good as if you'd had limb sparing surgery. Here's some patients who've had to have amputation. This is a patient with a large clear cell sarcoma around the ankle, really not salvageable, involving important structures around the ankle, the neurovascular bundle. But we know a transtibial, or that otherwise known as a below knee amputation, is very functional. And this patient went back to playing sports, which is not something we could have achieved, and had good surgical margin, not something we could have achieved trying to save the ankle and the foot. And here's a patient who's had a large osteosarcoma around the knee. And again, it's one where we made the judgment and discussed with the patient that there'd be so much soft tissue resection here, and we would compromise the margins, that an amputation was a better option. In children, we have to consider growth and predicted limb length. We want to preserve growth plates. If we do an amputation, it's better off through the joint. And they have more time to get used to it. And we can do some things. Again, apologies for this slightly surgical picture, but here we've had a child with an osteosarcoma of the distal femur, where rather than doing a transfemoral amputation, we've taken out the distal femur and we put the tibia on the end, and the tibia still has its growth plate, and there's still a blood supply to this bit of bone, which means that this has continued to grow as this child has grown. And so that's been a way of doing an amputation that maximizes her function. And sometimes here's another case where really we had no alternative. This is a child with telangiectatic osteosarcoma of the humerus, getting bigger during chemotherapy. Really all we could do was an amputation that's unfortunately at a very high level in the arm. But what about life after treatment? We talk about survivorship, which is really the experience of patients living with and beyond cancer. It's a multidimensional thing. So you can think about this affects people in many ways. And understanding what survivorship is like matters, because we want to know if people aren't doing well, if we know about poor outcomes, then we can try and improve treatments. We can think about interventions that improve outcomes, but we need evidence for that. And if we have a good understanding of what happens to people afterwards, we can help people who have choices to make decisions about treatment. There's a whole, when I said multidimensional, there's a whole load of things that affect patients. Fatigue, fertility, hair loss, pain, and so on. You can read that list on the left. And the NCRI, the National Cancer Research Institute, always used to talk about 9 domains of survivorship. So these are the areas of life where this kind of treatment can impact. Fatigue and physical functioning, pain, sexual functioning, cognitive function, and so on, employment, emotional distress. And so understanding how patients are coping, I think, is extremely important. But it's quite hard to measure this stuff. You can ask patients to fill in forms, and that's important. You can ask their clinicians to fill in forms, or you can also do objective things like measuring range of movement, like measuring how people are walking in a gait lab, like sending them home with accelerometers. We were interested in this for a while. I'm working with a team at UCL. We're interested in whether we could develop a patient reported outcome measure for all patients with sarcoma. that was recognizing that there wasn't really a good measure for psychosocial well-being, and also that sarcoma patients had particular issues. So then a project funded by Sarcoma UK and others to develop the sarcoma assessment measure. This has been an absolutely fascinating piece of work. We interviewed, or 121 patients were interviewed. They were asked multiple questions. They were asked 395 items each, so it's a lot of work for the patients. Patients were recruited through the charities, and the idea was to try and get a good feeling for how patients were managing after treatment. Items then reviewed, and it basically boiled down to 22 items, which comprised the SAM, and you can see these are the sort of things that patients report, or patients are asked to report on, right? So I do whatever I can to keep healthy. Do they agree or disagree with these statements? Basically, I'm more conscious of what I eat. I can do everything without help. I'm not as strong as I was. My procedures is heavy. My painkillers don't work. And so these are the kind of questions that give us some idea as to what's happening to patients. But during the process, we found a number of things. We found the patients talked a lot about their diagnosis, and we found that many people, and you won't be surprised to hear this, had problems with their diagnostic pathway, particularly teenagers and young adults, and particularly if they'd been offered an alternative diagnosis during their diagnostic pathway. Sarcoma patients talk a lot about fear of recurrence. It's a major issue for survivors, probably a bit more than other cancer types, and it's particularly in patients who lack psychological flexibility as a character trait. The other thing we found in bone tumor patients in particular, the 29 of those, the physical domain was really important, and how well people were doing physically made an important difference to their self-image and to their quality of life. And also that there was access to rehabilitation is very difficult. And one of the issues of being referred to a specialist cancer centre is often you can't come back to the specialist cancer centre for all your rehab. It has to be delivered closer to home. And so you're looking at asking people who've perhaps not looked after a sarcoma patient before to deliver quite specialist physiotherapy and rehabilitation, which is difficult. So they're patient-reported measures. What about objective measures? So we've done some work with particularly Sharon Furtado, who's a research physiotherapist at Stanmore, looking at objective measures. So what can you do? Can you use things like a Kinect camera or other motion tracking devices or accelerometers to give you some numbers, some objective numbers about how patients are doing? And of course, these things are important. So when you're trying to work out how patients are doing, you end up with some patient-reported stuff, some objective measures. And there is a way in which you can bring all these together, and it's called the WHO ICF classification. And there's a way in which you can bring all these things together to make some sense of how the patient is doing. And so we've built this into a research program, essentially, which we've called STOMP, which is the Stanmore Tumour Outcomes Platform. And we've brought together a collection of patient-reported outcome measures and objective measures. We do these measures on patients, and we then have an interview with them, the ICF interview, to try and ascertain how they're doing and to kind of fill in the gaps as to how people are doing. So this has been a project that's been ongoing for a while now. We wanted to make this quite a flexible platform, meaning that we don't want to do the same assessments for everybody. We want to do appropriate assessments for appropriate people. So if you've had an arm operation, you'd have a different assessment if you've had a leg operation, for example. We wanted to use this platform to support research and audit. And this is what I showed you before, which is essentially the ICF, which looks at body structures and functions, activities, patient-reported outcome measures, participation restrictions, objective measures such as accelerometers, personal factors and environmental factors, these contextual things that make a difference to patients. And so this is a prospective study. We're running it over 10 years. These are the first 88 patients. And again, just in the interest of time, I'll just take you through some of these just to see, just to show you how we're getting on. So this is basically, we've put 21 patients through gait analysis, which has been interesting. So we're very lucky at Stanmore to have a number of students who come and do master's programs. And so we've been able to use the STOMP data for master's projects. And we showed a couple of things about patients who've had hemipelvectomy. We showed that patients who've had removal of hemipelvectomy, removal of part of the pelvis, have poorer posterior and medial balance. measured by margin of stability, again, analysing these data, and that the gait speed is lower. And these things may seem obvious, but I think by getting more data about this, it allows us to intervene or work out ways in which we might improve this. The patient interviews are very telling. So patients say things like this: I'm terrified of crossing roads, I've been told not to run. And one of the things we have found is that doctors and physiotherapists and indeed implant manufacturers all have different ideas about what patients should be able to do after the operations that we've had, or that we do for them. I wish I could go skiing like before. I've received psychological support. I've had to refuse several job offers. I'm not bothered by my scars. So these are the kind of things that come up. Some patients show resilience. Some have come up with barriers to exercise. And again, physios at Stanmore work very hard to get people back into sports if they're interested. And there is a sports program where they can go and try different sports if they want to, which I think has been very helpful. Our patients have unmet mental health needs. The local rehabilitation is difficult. And we had a particular number of patients who had proximal femur replacements. And we showed something about their attitudes to walking aids, the fear of falling, and the way they adapt to get on with their lives. So I think as surgeons, we tend to do operations and not really know what happens to patients afterwards, but it's clear there are quite a lot of issues. One of the other things we've done is we've sent a number of patients home with accelerometers. So you wear this on your thigh for a week, and it measures at 100 hertz acceleration in 3 dimensions. So it'll do things like step count. So in the first 24 patients had about 6,000 steps, plus or minus 3,800. It shows people who've had secondary complications had lower physical activity. So if you had infection or revision surgery or pain, but it gives you a load of data. So this is the kind of data that comes out of an accelerometer. And so this is really important stuff, because this is what people do in the community. This is what people are doing when they're out of hospital. And we know that their activity does relate to their integration to normal living. So getting people back to normal living, we really want to increase their activity in the community. And this is a device that will allow us to measure it. Doing those complex assessments where you bring everything together brought a bunch of stuff out. People have limitations of activities you might expect. Things like using stairs, jogging, reaching into a low cupboard, getting in and out of the bath, in and out of the car. These are difficult things. Poor balance, low physical activity and energy level. A lot of people have pain. A lot of people are creative about adjusting what they do, changing their stroke in swimming, taking up new hobbies. People are frustrated and very often have difficulty accessing things in the environment and in social participation. So this platform's been fantastic, really, because it's allowed us to open up national and international collaboration. We've run 16 master's students projects through it. We've had 2 PhD students from Imperial College who are interested in a different thing, which is how children with amputation get on, and they're interested in developing low-cost 3D printed prostheses for patients. And so we've been able to support their development of these prostheses with our patients under this project. The SCORE workshop is a collaboration of UK physios and some from the European mainland, talking about projects in rehabilitation and physiotherapy. So it's been a useful thing. Just looking at the time, the other thing we've done is what's known as personalised cancer care. So all our patients at the moment, about 12 weeks after treatment, have a health needs assessment. One of our senior nurses who will come up with a personalised care plan. They'll review their treatment. They'll explain what's going to happen, what they expect next. They would explain things that they would look out for to come back to the specialist team. Some patients go to the HOPE programme, which is how to overcome obstacles in life, basically, which gives people psychological support. And again, that's supported by Macmillan, and we plug people into local and national support groups. Again, these are the kind of things that our patients are talking about. They're tired, they have difficulty walking around, thinking about the future, pain or discomfort. And on the right-hand side are the things that we've done about it. So we've sent people to health and wellbeing events, contact the GP, counselling, and so on. And so I think this is a really important way of addressing the holistic needs for patients. I think just in the interest of time, I'm going to skip over that. And just to say the other thing this year that's been extremely important has been the development of rehabilitation guidelines for patients, which they didn't exist in the UK. But these are essentially a discussion about what is good practice for sarcoma patients in terms of rehabilitating them. So in summary, surgery is an essential part of bone sarcoma treatment. Treatment is life-changing. Our patients have lifelong disability. The treatment should be personalised to the disease, patient, family, and their preference. But care of survivors and understanding their experience is really important to make sure patients reach their potential and get out of it what they want. So thanks very much. Lots of people involved in the stuff that I've shown you, including the team that developed the SAM and the STOMP team and so on. So, and also funders, of course, and not least the patients who've participated. So thanks very much. There may be questions. I hope that's been of interest.
Thank you, Craig. That was fantastic. Just a wonderful presentation just to help people understand bone sarcomas and a real insight into what you do day to day and just those operations and the considerations for tumours in different areas of the body. And just fantastic to hear about all the research that's going on, particularly to look at outcomes and what is important for sarcoma patients and survivors. So yeah, thank you. I might add, Craig, cisplatin these days is probably as cheap as chips. I'm afraid your implants are still very fancy and probably racking up most of the bill. So just send through your questions on the Q&A. I'll kick those off. I'll kick off with some of those questions, but please do send them through as we are chatting. So Craig, one of the first questions is, if I've been diagnosed with a new bone sarcoma, I think we're talking about osteosarcoma, what do you think are the important questions to ask my surgeon? So this is coming from a patient.
Oh, well, I mean, obviously there are many. I think and you'll find there are some quite useful prompts for when you're going to the doctor. You'll find them on some of the charity websites, a list of things you should ask, because obviously it's very difficult in consultations to remember everything. And that's another reason why it's good to take somebody with you. And very often people don't remember things, of course, particularly when you start talking about a new cancer diagnosis. That's the thing that people remember and the rest you don't. But I think what's important when it comes to the surgical bit, obviously the priority is removal of the tumour. And so understanding that you will need an operation, and so asking what that operation would involve, and what things I suppose have to be removed would be of interest, and what is something you might ask, and what your life would be like afterwards. There aren't always choices to make about reconstruction and about surgery, but where there are, it's important to know what people's preferences are. So, for example, for some patients, you could do a complex limb sparing operation. That means that they keep their leg, but it doesn't work so well, and it's difficult to do things like sports. But increasingly, patients will come along and say, actually, I do want to do sports, and I do want to be active, and I don't want to have to come back for more operations. And so I think, although it's not so much a question, I suppose, but getting that an understanding of what a patient does, what they would like out of the operation is important. I think it's very difficult when you're dealing with children, of course, because they're not the finished article. And so it's difficult to predict what the right thing might be for a particular child. But certainly if you're an adult, you understand who you are and what you do and what you like doing. Those are the very important things to bring into the conversation.
And just a comment on the numbers that you presented from NH England. I think that was the annual incidence, if I'm not mistaken. Yeah. So just sort of people commenting about the rarity and the low numbers. Obviously the England, huge population, sort of 56, 57 million in England, I think. But just the rarity of these tumours. Do you have a sense of why you've seen an increase in chondrosarcomas potentially?
It might be diagnostic. It's partly pathologist. We've got an aging population, so it is a tumour that's more associated with older patients, and so those are probably the main drivers. And I think it's always very difficult when you look back over the years over you look at the incidence of a particular tumour over the years, because pathology and pathological classifications do change a bit. And so what's called a chondrosarcoma now may not have been called a chondrosarcoma, say, 10 years ago. I think the quality of data that's been collected is also improving. I think that's the other thing to say. And so we've picked up, for example, a lot more Ewing sarcomas recently. And so the incidence of that, well, the numbers we're picking up has gone up.
Yeah. It's that importance of data, isn't it? Because unless you have accurate data, you don't really know the true instance. Yeah. Question about, do you have any experience or opinion on prehab for bone sarcoma patients? I think one of the audience members is potentially trying to get a program off the ground.
Yeah, that's a great question. That's a great question, because we know that prehab's important in a lot of cancer treatment, particularly patients that are coming up for big complex operations. Just having any kind of even a few sessions on an exercise bike can make a big difference in cardiovascular terms to people having big other kinds of cancer operations. We have written grants on it, and we've tried to get that off the ground, but we haven't been funded for that. I think there is a challenge with our patients. There's a kind of a very kind of basic challenge, which is that patients often have big tumours in the limbs. And so it's quite difficult, for example, to get on an exercise bike if you've got an osteosarcoma of the distal femur and it's very painful and you're in the middle of chemotherapy. But having said that, there are interventions that are appropriate and can be used. So, for example, the arm bikes come out a lot at Stanmore, and patients are forever in bed pedaling away on the arm bikes. And so I think it is important. I think it would be great to get prehab programs off the ground. We've struggled to do it kind of regularly. And actually, I think it's fair to say that although we're very lucky in that we've got a big, very interested physio team at Stanmore, that's very much the exception. And it's certainly much harder to get physiotherapists involved in centres where kids are getting chemotherapy, for example.
A similar question is sort of the importance or the sort of other key allied health professionals that you see in the treatment of bone sarcomas and where they fit in, alongside surgery, and I guess who are the other sort of key members?
Well, apart from physiotherapists, the occupational therapists is really important in terms of getting people back to home, particularly with upper extremity issues. So yeah, for sure, the occupational therapists. The CNS team are invaluable. They provide a point of liaison. There's a lot of care to coordinate for these patients because they're often in other hospitals at a distance getting other treatments. And the timing of things can change. And so it's always important to know what's happening with patients. So, and actually, other members of the team, the secretaries, for example, that are extremely good at communicating with patients, making sure that they are not lost to follow up and so on. And so, you're very much reliant on a big team for sure. Yeah.
And over the years, have you seen sort of an increase in awareness from GPs about sort of diagnostic pathways of bone sarcomas, particularly with sort of awareness campaigns that have come from such, Sarcoma UK and etc. Or do you think there's still a little bit of variability in that, time to diagnosis?
Yeah, how interesting. That's a great question. I think it's really hard. Okay, it's really hard because in the sarcoma centres, particularly in the southeast, traditionally we've been responsible for doing all the diagnostic stuff, and that has meant, certainly in our service, that the number of referrals has gone up 8 to 10% a year every year for the last 10 years. To the extent where we were getting about 130 referrals a week into the service. And when you look at 2-week wait referrals, the percentage of patients that has cancer, so 2-week wait referral, for those who don't know, is an urgent cancer referral. They don't exist anymore, although we still talk about them. The targets have changed. But a 2-week wait means you have to be seen within 2 weeks if you've got a suspected cancer. And so anyone with a lump would get referred to our service. And because it's really hard for GPs to get imaging in the community, where it has been traditionally, they have, of course, taken the precautionary principle and sent everyone to us. However, that has meant we've been overwhelmed, actually, and it's to the extent that it's been hard for us to provide care for sarcoma patients. So over the last 2 to 3 years, one of my jobs has been to try and sort out these pathways. And so although there is awareness, most people who may have a sarcoma actually need an expert ultrasound closer to home. And so if you live 50 miles from us and you're 80 years old, you probably need a scan close to home, and you'll probably have a benign thing. You need someone close to home who can sort that out rather than coming to the sarcoma service. So I think there is more awareness of it. I think what we're struggling with is sorting out those diagnostic pathways. There has in the UK been a move towards community diagnostic centres. So there are some sarcoma diagnostic centres where you can go, a two-way referral can be, someone like that can be sent and worked up. And there are a lot of urgent imaging now available in the community. One of the problems we've struggled with is that those scans have often been farmed out to third-party providers, and they'll do reports that say, this is almost certainly a lipoma, but I can't exclude cancer. So they're really not very helpful. And so we get large numbers of patients like that. And of course, that generates a load of anxiety. So to answer your question, yes, there's more awareness, but how we deal with that, I think, remains a slightly unsolved problem. We've made a little progress, but it's still a work in progress for sure.
Mm. So I'm going to do 2 final questions that I'll combine together. So where do you source your allografts for? And then maybe slightly more directed to Andy, are the fancy implants available here in New Zealand?
The fancy implants.
You can go first, Craig.
Yeah, all right, okay. Where do we get allografts from? Well, we usually start with the NHS blood transfusion service because they have a small number of allografts, but they're not. They don't have as comprehensive a program as there are in other parts of the world, particularly the United States. So the majority of our allografts come from the United States, actually, where they are, carefully screened and so on. And because size matching is important, you really have to get one that's the right size and shape for that patient. So that's where they come from. I'd say we use a lot more implants than we do allografts. And the reason for talking about them is just to show the kind of variety of things that are available and how you might tailor your reconstruction to that patient. I don't know, Andy's sitting next to me. I don't know what he wants to say about fancy implants.
So I'm going to squeeze on next to Craig. So everything Craig showed you, we do here. The only thing we don't do routinely is growing implants. We have just not traditionally done many of those. I did in the UK. We don't do them as much here, but everything else we've done, and most of it we've done in the last year. Never mind, once or twice, including the extracorporeals. We do use a bit more allograft. We like it for the top of the shin bone over endoprosthesis, and we do probably more rotationplasty here than we did in London. I don't know if that's changed.
No, that's right.
We've got a big group of rotationplasty patients, which is where someone's got a sarcoma on the end of the thigh bone that we think is difficult to reconstruct, and we take the bone out, turn the tibia around so that it's facing backwards, and the ankle joint forms the knee. So it's a kind of modified amputation where you've got a below knee amputation rather than an above knee, and it's incredibly durable, and patients can play sport on it. And in fact, when you see somebody walking down the corridor with their prosthesis on, there's one there that Craig's pointing out in the corner of the screen, you cannot tell they've had an amputation. They're incredibly functional. It does look unusual, and you really have to have the right mindset for it. But most patients who've had it, and the research will tell you they'd have it again. So we do everything that Craig has mentioned. We're a smaller country, and so we don't do them in the same volumes. But yep, absolutely, and everything is available here.
Wonderful, thank you. So I'm going to conclude the questions, and once again, just thank you, Craig, for your wonderful presentation tonight on bone sarcomas. So I'll hand back to you, Andy, to close the webinar.
All right, I'm going to stop sharing and just say thanks very much to Craig for taking time out of his family holiday to. As soon as I heard he was coming, he got press ganged. So I'm very grateful for him giving up part of his poor wife sitting on a hotel room on her own to come and give the talk, and we're very grateful. And that will go up on the website and a link to the YouTube channel so that people can go back and watch it again, or can refer other patients or people that are interested back to that so that it's there as a tool going forward. So thanks once again.
Pleasure. Thank you. Thank you very much.
Good night. Bye-bye.
Good night.